Welcome to Heart Failure Minutes. I'm Dr. Milica Vukićević. Today I'm delighted to be joined by Dr. Yuri Kim, Director of Translational Heart Failure Research at Brigham and Women's Hospital, for a focused discussion on the growing role of genetic testing in cardiovascular disease. We often think of genetics in the context of inherited cardiomyopathies, but its relevance is expanding into areas such as chemotherapy-related cardiac toxicity and myocarditis, where it may help explain susceptibility, refine diagnosis, and guide family screening. Today we will explore where genetic testing is most useful, where caution is needed, and how it can shape modern heart failure practice. Dr. Kim, in patients who develop cardiac dysfunction after exposure to cancer therapies, when should we think beyond the purely treatment-related injury and consider genetic susceptibility testing?
Yeah, no, thank you. Thank you for the excellent question, and also thank you for the invitation to be here. So, as you know, I think this is a really question that I think we have been increasingly recognizing over the past, 10, 20 years or so, that in the past that we really have thought that cancer therapy-induced cardiomyopathy was exposure-driven condition, that our patients receive this cardiotoxic therapy as a part of their cancer treatment, and that leads to cardiac dysfunction. Mm-hmm. However, I think we really realized in our clinical practice that patients actually behave differently, in that some patients develop cardiac dysfunction even with a standard dose of chemotherapy. However, there are other patients who are able to tolerate them very, very well. So that led to multiple recent studies that really has demonstrated that genetics appear to really play an important role in these patients' risk of developing cardiac dysfunction after receiving cardiotoxic cancer treatment. And I think this one, so we can maybe think of these as more the cardiovascular stress test, in that these patients are already vulnerable to developing cardiac dysfunction, but because they're getting this extra stress of the cardiotoxic cancer therapy, they unfortunately develop this cardiac dysfunction. So that's why, I believe, and a lot of us in the field believe, that, considering genetic contribution in this patient's population is very, very important. So, I think it would be very reasonable for us to think about genetic testing in any of patients who develop cardiotoxicity, but there will be also, some potential risk factors or the presentation that we can think about who may benefit from genetic testing the most. So if the patients were to develop kind of disproportionate cardiac dysfunction after cancer therapy, let's say they develop very significant LV dysfunction, or they develop cardiotoxicity even after a very low dose of chemotherapy, or if the patient actually, upon interviewing, reports that they have a family members who had a heart failure, cardiomyopathy, or unexplained sudden death, I think all those things really should trigger us to think about genetic testing. And I think those really thinking about genetic testing and looking for genetic variants in this patient population can definitely benefit their clinical management as well.
Myocarditis is often viewed as an inflammatory or viral process, but there is an increasing recognition that genetics may also matter. In what situations should clinicians consider genetic testing in patients presenting with myocarditis?
Yeah, no, that's another excellent question. So I think similar to the cancer therapy-induced cardiomyopathy, that again, the myocarditis, where genetic contribution to this disease entity has been increasingly recognized in recent years as well. So traditionally, as a heart failure cardiologist, that we often thought of myocarditis as a pure immune-related process that's caused by either the infection or autoimmune dysregulation. However, more recent studies have demonstrated actually patients carrying genetic variants in cardiomyopathy-associated genes are at higher risk of developing myocarditis. In addition, we also got to realize that actually some of the inherited cardiomyopathy can present like myocarditis. So especially those genetic variants in genes that are associated with desmosomes, such as desmoplakin or filament C. When patients carry genetic variants in those genes, they may present similar to myocarditis with evidence of myocardial injury with a troponin elevation, significant arrhythmia, and also inflammatory marker elevation and cardiac imaging evidence of inflammation as well. Because of that, we really would like to think about genetic testing in these patients with myocarditis as well. And I think some of the features, such as a really significant arrhythmia burden in our patient population, or if the patient were to have persistent LV dysfunction even after they recover from acute phase of myocarditis, or if the patient were to present with the recurrent episodes of myocarditis, I think those really features should prompt us to think about genetic testing in these cases.
For the practicing heart failure clinician, what is the most practical and disciplined way to approach genetic testing in familial cardiomyopathy, and how should the results be used?
Yeah, no, I love that question, and thank you so much for really bringing this up, because I truly believe, and many of really us in the field believe, that genetic testing is extremely important, and it can be really beneficial to many of our patients. However, that really utilization ratio of the genetic testing is exceedingly low. So really, I really hope, and we believe that really increasing awareness of genetic contribution to heart failure and cardiomyopathy, and really our clinicians thinking about genetic testing is really the big first step. And then really thinking about who to test. So out of our patients that we see with heart failure, any patients with heart failure, I think it's very reasonable for us to think about genetic testing. However, there are certain features that can also increase the yield of genetic testing. So if the patients were to develop heart failure at a very young age, I think that can really trigger us to think about the genetic risk in these patients. If the patient were to have significant arrhythmia that's really disproportionate to the cardiac dysfunction, that can be another clue telling us that it could be the genetic cardiomyopathy. Of course, really getting thorough history of the family members and really learning about whether the patient's family had a cardiomyopathy, heart failure, sudden death would be very, very important. However, I'd like to note that really all these disease-causing variants can have incomplete penetrance and then variable expressivity. So even if the family has a genetic variance that's running in the family, unfortunately, not all family members may have heart failure or cardiomyopathy. So recognizing that limitation will be also important as well. And I think genetic testing is, really has a great benefit for our patients. The reason that we really want to advocate for awareness in genetic testing is it not only really helps with the diagnosis of the condition, but also it helps with prognosis and also management of our patients, because depending on what type of genetic variants our patient has, that can really change how often we see the patient, when we would recommend the defibrillator for our patients. So I think really understanding the genetic basis of disease will be helpful and improve our patient care.
Dr. Kim, thank you very much for helping us understand how genetic testing is becoming an increasingly important part of modern heart failure care, from cardio-oncology to myocarditis and to familial cardiomyopathy. The field is clearly moving toward more precise and individualized evaluation, but with that comes the responsibility to use these tools thoughtfully and in the right context. I'm Dr. Milica Vukićević, this is Heart Failure Minutes, and I'm signing off for now until next time.